of the C4P vaccination and screening and treatment tool. A few weeks ago, when we were in Bhutan, I think, was it, Anne, or Myanmar? I can't remember. We were asked if we could provide a training for people who were going to be going out under the auspices of CHI to conduct costings of cervical cancer prevention through HPV vaccines and screening and treatment through screening and treatment, of course. And so we said we'd be more than happy to, but we thought that it probably wouldn't be worth anybody's while to sit here for 8 hours and stare at each other. So we've asked that we kind of break up the sessions into 60 to 90-minute sessions. We weren't sure how much you knew and where your pain points were on each of these each of these costing tools. So we asked that we spend the first hour, hour and a half here actually discussing what you do know, where your pain points are, so that when we can then go back and we can develop specifically targeted trainings to provide you with the information you need to move forward with your activities. So you know Anne is the health economist on this team, and you've been working with costing and costing tools for how many years, Anne?
10 to 15 years.
10 to 15 years, wow. And we've been working with Raymond and other folks for about 10 years, I think now, isn't it, Raymond? On doing costing tools. The first one that we worked on was redeveloping the CMYP. Is anybody familiar with the CMYP? Okay, yeah, we didn't work on the calculation part, but we tried to take it on and make it a little more user friendly. And then we were asked by Raymond to develop a tool for costing the introduction of the HPV vaccine, and it was specifically for Tanzania at the time. And people have liked it enough so that they've been using it since then in other countries. Now, what you're going to see is the tools are set up quite differently. The first one is a total Excel model. There are no macros in it. There's no VBA, nothing at all. So it's a very transparent tool. The second one is a little bit different. It uses an add-in that's called Modano, which forces one to use best practices when one is completing a financial costing model. And I'll show you the back end of that in just a little while. But first, before we do that, we'd like to get an idea of, from each of you, is what have you been doing, starting with the vaccination tool, and where have you had pain points? What we're going to do, so you know, is we're going to start writing down what those pain points are, and then we're going to develop a seminar or a webinar for you that we'll do on Wednesday, which will help you to move through the pain points. So can we start with one of you, please? Joss, Cindy, Sophie?
Well, I guess I can start because I probably have the least experience with this. The C4P tool is completely new to me, although I've spent some time now looking through the module that was sent to us. I'm quite familiar, though, with working with large-scale microsimulation model. I run the UncleSim model for the Canadian Partnership Against Cancer, so I have an idea of how models work and how they're put together, and interfaces of large-scale models, and particularly with the interpretation of results, which is what I do as a living when I'm not at IARC, is to help policymakers make these kind of choices in a high-income setting. And we have also a cervical cancer model, which is very similar, I believe, to a Marc Brisson's model. that was part of our gut. So I do have some familiarity with some of the terms that you'll be using and how these models are put together.
Hmm. And Cindy, you've been going over the vaccine model, right? Have you have you taken a look at it?
I have, yes. So I've looked through each one of the worksheets as well as sort of the overall organization of it. So I'm following along with the user guides a little bit to the point where I can probably at least understand what I should be doing if I were, say, a technical analyst within the ministry, for example.
Hmm. And tell us, have you found certain points that are confusing you, or places what you'd like to know more about, either the logic or the operational part of it?
I think what I had a little bit of problem was with the navigation. So, for example, when you go between the left navigation, let's see, I'm just going to try to find an example here. Is sort of the interplay between the tabs at the bottom of the page and the tabs at the top of the page. Because what I understood was the labels page, for example, on the setup menu sheet.
Mm-hmm.
So if I went to, say, for example, setup, and then it would define a certain number of sheets and the bottom I thought would become live, but actually they could become live even when you're in the entering worksheet data part as well. So I wasn't sure how one would govern the other and one would block the other, because I know that in the user manual you were very specific and definite about doing the setup first before you actually work on the worksheets. But it seems to me you can go back and forth quite easily. So maybe there's some kind of a check, a logic check at some point where if you get confused with where you are, it would help. But I was confused going back and forth between the two levels.
Okay. Mm-hmm. Mm-hmm. And were you able to figure that out after a while, or are you still confused?
No, I think, when I looked at the worksheet some more and stuff, I was able to at least orient myself to where I was. But I still haven't, I don't know if I actually was entering data, I might be lost. I'm not quite sure. I haven't gotten that far yet.
Mm-hmm. Okay. All right. Anything else?
No, I think that was my pain point for now.
Mm-hmm.
I think, yeah.
Mm-hmm. Joss, are you still there?
Yes, I'm still here.
Oh, okay. I didn't see you there. Do you want to share how you're coming into this and what your pain points have been on the vaccination tool so far? Thanks.
Well, I worked on the total system effectiveness tool, and the idea here is that the impact of different rotavirus products would be analyzed in like a big tool and looking at different aspects of impact. So not only health impacts or like case of birth, but also different cost components. And when this project was started, the idea was that we would combine existing tools into one big tool. So the way I use the C4P tool is I look at the different components that were in the C4P and how these outcomes were created in the tool, and I kind of copy that into the TSE tool as it stands now. So I didn't actually put data into the C4P tool, but I just look at the methodology and copied some parts of the methodology into the total system effecting simple model.
Oh, that's interesting. So it was transparent enough to let you figure that out, do the logic, and to copy and paste?
Yes, yeah, I thought it was really clear.
Okay.
So I haven't put data into the model, so I'm not. I don't know how user friendly it is because I only look at the methodology and how it's set up for the user.
Well, I always say it's always as user-friendly as the developers are friendly to the users when they get any questions. So that's one of the reasons we're here. And I mean, the other thing is that we're delighted that you're taking it and using it for other kind of repurposing it. That was part of our intention at Levin and Morgan, is that we felt that most of the models that one saw when we were starting were black boxes. We call them black boxes. You put in data and then a miracle occurs and you get your data out. Yeah. And it was kind of hard to follow the logic. So although our models are a little bit longer than others people's, well, okay, they're a lot bit longer. We tried to do everything kind of step by step.
Yeah, that's very nice about this C4P tool.
So you could see what we're doing, and so when it does work, we're happy. When it doesn't, we're not. So, all right. So you haven't really tried putting data into it yet. So you're just you don't know your pain point yet, right?
Not yet. I have no pain points with them.
Okay.
Not yet.
Okay. So who's next?
I can go ahead. So this is Sophie.
Hi, Sophie.
Yeah. So my experience with this tool is that I'm currently helping with kind of the project management and the communication of this cervical cancer elimination costing project. Mm-hmm. And for two of the countries we're working with, Nigeria and Zambia, mm-hmm. The C4P tool has been used for the costing of the HPV vaccination and the screen and treat campaign.
Mm-hmm. I think that was Zambia. Who was Zambia? Do you remember who did that one, Ann? Was that Amos?
I worked on Zambia.
Well, on the screening and treatment, how about vaccination? Do you remember?
I don't know the vaccination.
Oh, okay. Oh, was it? Okay. All right. And then it was Denyi, who was it on Nigeria?
Also Referral.
Oh, okay. Okay, great. Okay, sorry to interrupt you, Sophie. Go ahead.
No problem. So my role with those countries would be, along with everyone else on this team, to review the data that's been input and take the outputs and put them in a report. And also, in the future, some of the other countries we're working with will want to be completing the C4P tool as well. So I think I've basically gone over the completed tools for Nigeria and Zambia, taken a look at them, and I think I get the overall logic. I do have some questions around. I think one thing that I'd like to go over is kind of like the definitions of what when we're talking about coverage rates or active and inactive areas, what are we talking about exactly, so that we can sense check the data that we're getting from countries. One thing I'd like help going over with as well is understanding the logic for the population output calculation. And yeah, and then general, actually I'd noted on the navigation as well, for especially for the vaccines tool, kind of joining the questions that we had. And I also had a question. I've noted that the two models, they give the possibility of going very much into detail, into like subnational, regional, provincial level. And I was wondering if it's possible to kind of take a shortcut and just have national inputs we plug into the model if we're not getting the detailed data.
Right. Okay. And I think can you hear me?
Yeah.
Okay. Wanted to make sure that I hadn't muted myself again. So we want to make sure that we're clear on what the definitions are of coverage rates, active versus inactive. We want to go through the logic so we know why are we getting certain population outputs. On the vaccine, like Cindy said, want to just look through the navigation to see how we're doing the navigation, and to understand the logic of having all that navigation, I guess. And then can we take the shortcut to like national? Can we just do one big one instead of having to go through all the regions or provinces? All right. Anything else?
Those were the big ones, and then since I personally don't have a health economics background, so I'm happy also to just have the general training on the tool. Yeah.
Oh, that's good. Yeah, I like to say I'm a recovering health communications person. So it's I'm sure that you and I get at least you're starting where I was starting when I started doing this. Is what is this health economics stuff, and why do I have to know it, and what does this mean? What does that mean? So do feel free as we're going along to stop us and ask questions, because those are questions that people in the field will often ask, like what's the difference between financial and economic costs, and what is this annualization, and why have you done this to me, kinds of things. So good. That's good to know. So we've got Cindy and Joss and Sophie.
Yeah, from us over at WHO, we have a pretty wide range of experience with the tool, as well as a few different functions that we're having with it. So part of what we're going to be doing is verifying the data that's coming in from countries, and as well we're working on a database of costs that we're using a lot of data that's coming through the C4P tool. And one issue that we are seeing is when we're going through different updates of different versions of the tool, if there is a better way that can be identified for moving data, so it's not as manual, I guess. I think that would be big for us.
Since we have several versions of the C4P tools for vaccination, so when we receive some offers from the countries, then what we are doing is copy and paste the input down to the latest version, because the latest version should have the most correct formula. And so when we copy and paste and we identify the correct space, and then we need to find out, so the input cell should be yellow and the blue cell is what's the calculation. And we need to compare the blue cells, whether there's any difference between the original country file and what we are doing the revised file, and whether the difference is due to the corrected formulas or really still due to some errors in between. So one thing is when we come over some difference not due to the formula update, we need to find out what's the reason behind. And one main thing is some country consultants may hard enter the blue cell, which is not supposed to do so, and maybe they think it's more applicable to their situation. But sometimes it may violate the assumptions behind the C4P tool. So, but I don't know how we can deal with it. Maybe one thing is what we are doing is copy and paste the science tool and find out the problem. But now, what the country consultants still using the tool is not fixed, like they can correct all the cells. I don't know whether it will be helpful if they use one protected so that they cannot change the formula. But I don't know if it's really good to do so. And yes, this is the main thing that I find. Yeah.
Anything to comment on movement?
No, sorry?
Is pain points?
No, I don't have specific pain points. And I constantly learning each time I go into the sheet more detail. There's quite, the tool itself kind of is very in detail. But still, from my experience, also when other people, consultants have been working on the tool, consultants are often asking for more options. For example, do this tricks is not enough. More detailed this trick, and you see, for example, people have used the tool for vaccinations in Zimbabwe, found the tool very restrictive. So there's a whole range of users on the C4P over the last couple of 5-6 years that the tool is kind of used for HPV vaccination. People are kind of really happy with the tool. Others find it too complicated, but also then people find it not detailed enough and not flexible enough to reflect, the wishes of the consultants. And also based on the discussions with the Ministry of Health with whom we are working. So I do think from my own experience working with the tool, I think the tool needs some facilitation with Ministry of Health people. You can't just throw the tool to the countries and then expect them to use it. It needs to have some training or some background how to use the tool. And in particular, I think that there's maybe perhaps not so much for the vaccination module, but for the screening module, you really need to go to the course and have some experience with it before you actually use it. So, hopefully.
Yeah, one last thing. I want to reiterate something I think Sophie mentioned earlier. A lot of what we're doing is really about communication, and when we're going to be really passing this tool on, it's important that we have very clear definitions of what each of the inputs are so that we have consistency. So if there is a better way to clear that up, I think that would be important in these sessions as well. Thanks.
Cindy, you had your hand up?
Yes, I did have my hand up. I was just, I didn't want to interrupt Raymond, but I could barely hear him, and I know he has some good feedback here. So maybe, I don't want you to make you repeat everything you said, Raymond, but if you wouldn't mind sitting a little closer to the mic, that would be great. Yeah, sorry about that.
Is this better?
Yes.
Yeah, sorry about that. So in a nutshell, I was saying, since we are disseminating the tool, in particular the vaccination module, to different consultants and also to different people in the countries, particularly Ministry of Health, the experience for me so far is that we have a wide range of kind of observations or experiences with the tool, varying from countries or consultants find the tool useful and good enough, to people who find it too complex, and others find it not detailed enough and not flexible enough. So you have a wide kind of range of experiences on the tool, and I have to say, this is it's not a kind of a very complex tool, but it requires some kind of background and also understanding of the philosophy behind the tool, why we are using the tool, for what purposes, and I think it is also needs to be clarified for the screening and treatment module of the tool. And I think if you have read the user manual, it becomes more clear what the background of the manual is, or what the idea of the tool is, why we have developed it. And yeah, I think it's understandable that people have different kind of experiences also, because the countries are also different. So
yeah.
Okay.
Absolutely. Thanks, Raymond.
Yeah, I totally agree. Yeah, I mean, yeah, definitely. I guess the nice thing is it's getting interest. Can you hear me? Just want to make sure.
Yes.
Okay, good. But I love how some people say that it's not complicated enough. It doesn't allow you to do certain things, and some people say it's too complicated. So we must be hitting some kind of medium at least where people are are saying, if only it could do this, if only it could do that. That's I always think of that as a good thing to have, because if as we are also working on a new version of the C4P vaccination tool, this is also a great opportunity for us to look at ways that we can improve it, not only its usability, but its functionality, and streamline it where we need to. So this is really good feedback. Anyone else who wants to come in and suggest, or tell us how they're using it and where their pain points might be right now? Nobody?
I just want to follow up on what Raymond was saying about the users, because from my experience with our black box, it's really hard for users to conceptualize how the whole thing is put together, and perhaps maybe some kind of a diagram at the beginning of your user manual would be helpful for some of those who are more graphically oriented, to see how the data flows through the system and how the whole thing just hangs together.
That's an interesting idea.
Yeah.
I'm just wondering, at one point we had that and we got rid of it. I'm just looking to see if we still have that in there. No, we took that out. That's an interesting idea. You're thinking if we could have some kind of like algorithm so people can see how things are moving through the tool?
I think so. I think that might be helpful. And, just really basic, rudimentary kind of a graphical depiction would be helpful, I think, because you don't want to stun them right from the beginning.
Yeah, I'm with you.
Yeah, because I think that it is a fairly complex model, and the way the data moves through that is not linear, of course, and so, but yeah, some kind of conceptual framework would be nice to have right at the beginning.
Now, let me make sure you're still talking about the vaccination tool, yes?
Yes, I haven't looked at the screen and treat one yet.
Oh, no wonder I haven't heard any. Okay.
Okay.
That explains a lot. Okay, good.
Would you have that in the screen and treat?
We do have it,
okay.
And that was something we understood that would be useful. It was a devilish to get it done, though.
Yeah. I think I saw a version from Raymond. You had sent me one earlier on, and so there was some, but I haven't looked at it in detail.
Let's see if we still have that.
Can you repeat what did I send you?
Yeah, I think in August or September maybe, I saw that version.
I sent you a screen on the vaccination module.
The screen one.
Yeah, it goes with the menu.
Yeah. But I admit I didn't go through it, the whole thing.
Okay.
Yeah.
Okay, yeah, I think it's in here somewhere. Where do we have this? Just looking. Outputs. Summary dashboard. Yeah, we had it. I'll have to try to find it again. Anyway, okay, good to know. All right. So if there's no other feedback and pain point questions about the vaccination tool, should we move then to the screening and treatment tool? Okay, I'm going to tell you a little bit about the screening and treatment tool as as we're going in here. You'll see this is one of the versions of the screening and treatment tool here. And it is designed on a very different platform here. Although it doesn't use any VBA or any macros, there is a program called Modano underneath it. And what Modano does is it sets things into modules now. So this entire model is modularized within Excel. Now you should be able to see can you see a graph here?
Yes.
Or you can see an organogram?
Yes.
Right. Okay, so what this does, I'm just going to move this out of the way, is that you have a time series, then you have all kinds of different modules like a screening service modules here, intervention modules here, places and facilities, diagnostic pathways, and each one of these has its own inputs and outputs and lookups sections, so that basically if you make a mistake in one of them, then it's not going to screw up the rest of the model. The biggest problem we had with just working with bare Excel is that it was really easy for us to make a mistake and miss the mistake that we made. So you'll see that all of these are linked together, right? Here, so customization is linked to screening methods, is linked to everything else. So what we do basically is we build these modules individually, where we have assumptions, outputs, a summary, and lookups, what I think you would call variables, and then we link them using a linkage program. Basically, if you go into the module areas, you can see it's pretty complicated here, how everything's linked up, right? But it's done in a way that's supposed to help us prevent what I call stupid errors, which are the ones that developers make. And so it should help us to be more accurate. Now, I don't usually show this to users, but since you are all involved in developing models in Excel, I thought you might be interested in Modano, as this is a great way to build models in Excel without getting into the problems you usually get into. All right, so there's that.
Wynn, do the users have any way to change those linkages? So I'm thinking, for example, of a screen and treat algorithm where they may change the order of, say, triage, or put in other a couple of more steps for triage, for example, after the primary screening.
Yeah, well, what we do have is when we go into our labeling, right? We do the HIV labeling, and then you get into your assumptions. That you can start going into how they're going to work through this. So the referral assumptions, basically. So once you've screened someone, you can decide here where you're going to where are you going to refer them right after a screening. So if you, in this case, for example, if someone gets screened, basically, then where do you send them to? Like, you can send them for a further diagnosis, a pathology, and you can decide that's the way you're going to go through that. But I'm just looking here again. I think we've kind of set it so these are these are basically the options for you to do here. Let me just check this. This is why I want to get your questions first.
Right.
And then move. Yeah. Actually, yeah, you can change it. So you can, so that's right. So if let's say you want to do a different screening than visual inspection with acetic acid, all you have to do is change the name of it. So let's say we wanted to do, I don't know, cursory inspection. I know we don't want to do that. But if I do that, then you'll see cursory inspection now becomes the thing that you're doing throughout. Okay, and then when you start going back through on your labels, you're going to see. Stop it. You're going to see that you're going to have cursory inspection here. So you can have up to 3 different screening methods here, and then you can change all of your follow-ups as well. So you can have diagnostics. I think you can have up to 3 diagnostics right now. You see, so you can do diagnostics, and then your treatments you can do the way you want to, and then you can move them in proportions according to what you want to do to decide which way it's going to go through. Does that help you at all?
Yeah. I was just thinking, like, some of the primary screening methods now could be used as triage methods, and I was wondering if you move them. Say if you had HPV followed by PAP, would that change the algorithm below for choosing diagnostics or not? But it didn't look like it changed when you just did that.
No. You can, but that's going to be a subject of another training, because that's going to get a little complex to show you how to do that.
Okay. So we can follow it up another time.
Sure. Okay. All right. So, I guess I'm not sure who has actually gone through the screening and treatment module yet. If you have, could you please let me know who you are, and can you let us know where you're finding pain points? Okay, not everybody at once, please.
Hey, Wayne, our remarks from this side were for both the vaccination and the screen and treat.
I'm sorry, come again. I didn't hear that.
Our comments about pain points, those were for both screen and treat and vaccination.
Oh, okay. And that has to do with locking the thing down, first of all. And I think the graphic, definitely. And you're having problems with the database of determining whether or not people had changed the formulas. Is that right?
Yeah, and also a way in which we can move data between with updated versions.
Yeah, that's going to be tough. I'm not a database guy, and I know that one of the ways that you could do that would be to name each one of the ranges, and then you could call those ranges for a database. But I haven't done that before, so that's a tough one. The other thing that we found was that when you do change versions, is that often you're adding data ranges that weren't there before. And in that case, then you have to go back to the database extractor, and that can also get complex. So I'm not the best guy to talk with about that. I'm sorry. I wish I were. Well, okay, so I'm not hearing so much about the screening and treatment yet, which is interesting, because that, for us, that's one of the most complex ones. Just so you know, when we started designing this particular program, the costing tool for the screening and treatment, we did not anticipate that this was going to be used in the field without someone who is either well trained in this particular module, or who has experience as a health economist. So it was designed with the idea that the type of person who was going to be using this was not a field program manager in this case. But the idea also was, if you were a technical advisor, that you would put together a planning and costing team consisting of people in the government and NGOs. If also you had people involved in this, and you would gather them around this particular tool so that they were all looking at it and it was being filled out together, or it was being reviewed together. So it was more of a facilitated tool than the vaccination tool was. So what we've found when we've used this in the past is that it really helps to have someone who's very familiar with the tool go in and work with a group of people to fill this in. And I think, let's see, who said? Oh, Sophia, you're doing communication coordination. Yeah? You still there, Sophie?
Yeah, sorry, I was on mute. Yes, okay. I am.
So are you familiar with the concept of a social object?
I'm actually not.
That's fine. Okay. Well, a social object is actually either an activity or an experience or product that causes people who are not necessarily in a cohesive group to focus on something outside of themselves. So they focus either on an issue, or they focus on a particular problem, or on a puzzle, and it causes them to become a more cohesive group. And so, like I said, I'm a recovering communications person. So actually, this tool was designed with the idea that people would gather around it, and they would focus on what's being put into and coming out of the tool, so that by the end of that experience, they would all have been, they would form a more cohesive group or team that's interested in making what they planned actually happen. So as you go out through this throughout, you'll see that there's a lot of inputs here, like here's a program rollout schedule, and there's a lot of critical assumptions that go in, which are actually foci for discussions with the team that you work with. So having an individual fill this out may not be the best use of it. If you do have an individual fill it out, then we strongly suggest that that individual presents it to a group of people for discussion. All right. Now, someone asked if we could just bypass the rollout schedule, like instead of just doing the different regions, just do the national one. So this was designed so that there would be a rollout of the different of all the areas, basically. So some provinces or regions would start in 1 year, some would start in another year, and some would start in a third year. And that in itself complicated the logic of the tool. I'm sure that those of you who work with tool logic can imagine, because we had different programs start years, and then we had to go back to summarizing for calendar year for costs. As to whether or not you could just do one national thing, I think that might be possible, actually. You would just have to say national here, and the number of districts would be the number of districts in the nation, or the part of the nation that you're going to be working with. And then when you get down to the different numbers of things that we could probably finesse that. But we'll actually probably have you do that as an exercise. That might be an interesting way of doing things. You're going to find that this is, as I said, a more complex tool. And there's although you have the currency codes and the exchange rates and things like that, this is where we also have what's called a master price list. And I think those of you who've done costing before know that there has to be a price for everything, unit prices for everything, as well as package prices for everything. So you're going to find that this here, what I'm showing you now, this master price list is going to be one of the more difficult things to fill in. And one of the things that we've done here, as you're going through this and looking at it, is you're going to see that all the information that's currently in there has a 2-letter designation in parentheses after it. And what that is that's referring to the cost that was given by a particular country that has worked on this. So, for example, we had Zambia and Uganda and Tanzania in this particular case. So we just had left that in, saying this is what the cost was in Tanzania. If we knew the year of costing, we tell you. And then, so you might see the same thing 2 times or 3 different times in here. So as you're going through that, just be aware that that's what's going on. You're going to have the ability, if you want to just clear all this out, all of this whole master price list that you're using, and put in only the prices that you think that you want to have in that particular place. But be aware that this is going to be a critical part of this tool. As I said before, you're going to be able to have screening, up to 3 screening activities here. You'll see in this case we've used only 1. If you want to add another screening service, you just let me know and I can add that in for you. Okay? So you're going to put in up to 3 screening assumptions. You're going to have, we had diagnostic pathology assumptions. We have 1 right now, but if you want to have a second one, we can also put that in for you. Make a note of that, please. Now, Raymond, I have a question for you, please. Previously, we had said that we did not want to have pap smears or PAPs in there. Is that still the case? I know that's going to be a question here.
Yeah, so some countries use pap smear, but for the upcoming given this initiative of second elimination, we are more kind of ambitious, where we would like to look at the cost over the next 5 years, 10 years for HPV testing. And I was just asking, for example, there we can still add that also as an option, so HPV testing. But as you said, you can put in 3 types of screening tests. I mean, we see that most countries use VIA, but I think we should also look, for more ambitious type of screening tests. Is that hello?
I'm trying to unmute myself here.
Okay, you are unmuted.
There, I'm unmuted now.
I think Fayad was controlling.
Well, so Raymond, does that mean you would want to have pap smear as a screening option or not?
Yes. I mean,
okay.
It doesn't complicate too much.
No, we have 3 in there.
Yeah.
Now, the question's going to be really that we had before is when you have someone in there screened in one way, Now, we call it a diagnostic, but it's like a confirmatory screening or a diagnostic. Would you want to have the pap smear as a diagnostic or as a screening?
Excuse me, Win, does it have to be fixed? That is one or the other? Because I can see in some countries where PAP could be used as a triage, so a confirmatory, right after a HPV test. And I think Latin America might be going that way because they have the PAP infrastructure already. It's just not being used very well. But if they go to HPV on a large scale, they can use the PAP to further triage because HPV is so specific, right, for example, and too specific.
Mm-hmm.
So, if it can move between being a primary screening tool as well as being confirmatory is what you're calling it, I think. We call it triage sometimes, but if it could be, it's really to reduce the numbers of people who actually go into a diagnostic, say, a pathology stage where they have to do a biopsy or do further follow-up, right? So it's almost like an intermediate, which is why I was asking whether those algorithms are set in stone or not.
Well, it is from screening to diagnostic, but I'm going to take a look at it and see what we possibly can do. Okay. The other thing could be that if you do, I guess my question would be, if you do a diagnostic that's a pap smear, would you then go and do a second diagnostic that would be a biopsy?
It depends on the results of the pap smear. If the pap smear is also positive, they could go to a biopsy. But, that's very expensive, of course. So, it could be that the country will just refer them to treatment at that point.
Okay, I'll look into that, and we'll see what's possible. And then I'll get back and answer your question later in this, this ongoing training, if that's okay with you.
Okay, great.
I know we had questions and problems with this before. I think we may have solved it, but I'm going to have to just reboot my brain and see what we did. Okay? All right. Now, as I said with the interventions, you can name your own interventions here, just so you know, in each case. And the intervention names will be going on on this page here, the intervention assumptions. And those will change every time you change those. All right. And as far as non-service assumptions, don't have a whole, well, we have supervision and monitoring, we have communication support, and these are a lot less detailed than the other activities here. So you'll find that when you're working with this particular tool, that it really focuses a lot on the screening and the treatment parts and less on the non-service parts. Although you're going to find out that there are things called plugins here, and as you look through them, let's see, I'll ask you to look at those. In the appendices, you should. Do we have that? Yeah, these things, these little purple things, which are, I call it a training budget creator, things like that. Okay. Yeah, and of course that's not working right now. But as I said, I'll go over that with you much later. And while I just have this up, I want to show you one thing. Which is the model logic. Let me just look at this here. Okay. Stay with me. Here we go. What I was trying to find you is the model logic, which I had in here somewhere, which responds. Here we go. Yes. This was, I think, the question that you had Corrine before, right? Is there somewhere where you have like a model logic? Yeah?
I think Cynthia was asking for that.
Mm-hmm. So this shows you here, like, and this was something we were working with experimentally, right? So if you go up here on this model logic and you say, okay, it will show you, here's the eligible population. It pulls that. And then you can see, here's the number that don't seek screening. And then that takes you over here. Then you can see, here's the number who sought screening, or percentage who sought screening in number. And then what percentage of the demand was met based on the maximum capacity. How many received screening? Okay. You see no one was turned away. And then based on the screening, you could say, okay, this percent had a normal screening result, so this is people who are normal. This is who were referred for diagnostic pathology. And then you can see the dropout rate here. This is the number that were referred for LEAP and referred for cold coagulation. And then here, if you're referred for diagnostic pathology, then you can see how many went and then received each of the different treatments. Now, Karina, if you're like me, you're probably saying, didn't I say that I wanted a simple one? Right?
Are you referring to me?
Yeah. You were going to say, can we have a simple?
Yes, absolutely.
Yeah, sorry. Yeah. Yeah, this is not so simple, but this is the logic of this particular model.
Mm-hmm,
So
mm-hmm.
if you look at that, it's under model logic, and you have any suggestions as to how we can make that more simple, I would be delighted to hear them.
Yeah, it's not so much the actual pathways, like the clinical pathways I was thinking of, but more of just the input-output flow of data. But this is very helpful, actually, I think.
Yeah, this is kind of scary, but it also does error checks for you, right? So it's interesting. So if you see that, and also it tells you if there's any bottlenecks, like where people are looking for particular care and they couldn't get it. All right, this is all based, and all this is based on what you've put, you've input there. Mm-hmm. Okay, but I didn't want to spend a tremendous amount of time actually presenting either of these tools, but I wanted to get a sense of your pain points from where you were and how you planned on using this. So, Anna, is there anything you want to ask or any other questions? Dr. Levin, are you there? Are you on mute?
Yes, she is.
Dr. Levin?
Can you hear me?
Now we can hear you.
Yeah, I don't have anything to add right now.
Okay. All right. So what we propose, if it's okay with you, let's start with vaccination, okay? And we will meet with you on Wednesday at 9 a.m. And we're going to go over the vaccination tool based on the information you've given us. We're going to talk about how the setup works, why the setup works. Okay, we're going to talk about locking the tool, just so we make sure that you know how to lock it. And we're going to see if we can have a diagram ready for you that shows the input and output. I understand that, Sophie, your interest in the population output, that had to do more with the screening and treatment, did it? Am I correct?
Yeah, it was more on the screen and treat, but I'm happy to actually just, for also the vaccinations.
Okay, all right. Okay, and and we're going to go over the navigation, and we're going to go over, can I just do a national one instead of doing regional one? Okay, and Raymond, is there anything in particular you'd like us to cover on Wednesday?
No, I think it's, like Cindy said, you know, the logic and maybe more also the philosophy of the vaccination module that will be helpful from the start, so that we are all on the same page, that we have been actually using this for more prospective costing and planning. And and you need to have a facilitator to use this version of the C4P vaccination module. But no, I think nothing specifically. And perhaps also emphasize the limitations in sense of, you know, that we actually going into detail two or three districts. I think it is 2 districts now, and also that will be used as a basis for the other districts in the country.
One thing I'd like to add is feel free to use some of the Zambia and Nigeria data that we sent over in your demonstrations or examples. I think that might make things a little more clear.
Yeah, that's correct. Yeah, because those are 2 countries currently, Nigeria and Zambia, who actually have done with their program managers, both on vaccines and on the reproductive health and cancer programs. Those program managers have gone through all the assumptions, and they have, at least for Nigeria. I think for Zambia, they are still discussing the validation of all the assumptions, but in Nigeria, they have presented both the HPV and screening modules to the program managers, and whether they agree with all the assumptions behind the tool. And I think it would be good to use the Nigeria example with the numbers in it to make it more concrete.
Okay, great. And just so you know, I'm also, as we go along, I'm also doing some sheet by sheet overviews of the tool. I'm starting with the vaccine tool, and I'm going to put that up on YouTube just so you can see it. And I'm going to use some of the questions that you had now to redo those, but they're going to be like 5-minute videos at most each, just going over each of the sheets and also doing some overview. So I'll share those with you when they're done as well. They're just pretty informal like this.
That would be great if you could do that, because that will save us time and we don't have to go through all the kind of I think that will save time, and also will have opportunities for specific questions.
Sure, not a problem.
Thanks a lot.
Okay. Well, is there anything else that's burning? I don't want to keep you all for 90 minutes just because we said we were going to go up to 90 minutes. I know you're all very busy.
Gwen, I just have a question. We're looking at version 5 on your screen, but I think we've got a different version. Is there a big difference between what Fayad has sent us and what you're going to be using for those videos and for filling out?
Yes, you should use version 5.1 C multilingual. Okay. And the big difference is going to be right here. Can you see my screen still?
Yes.
Okay, and that's going to be something that we added, which is I call it a reality check.
Mm-hmm.
We found out that people can easily make the mistake in the service delivery of overburdening the service providers, or sending out too many service providers for particular activities. And so we put in this reality check that shows you, hey, if you send out, these people, you're going to have, way too many people here. So maybe you don't need to send them out, this many times or whatever. So we'll go over what that reality check is. But now, Fayed, you have that one that's 5.1C?
Yeah, I think that's the only one I have. I'm pretty sure that's the one I sent over. I'll check.
Okay. All right. If you do that, that would be great. And secondly, do we have the Nigerian one? I'm just the one that was filled out for vaccines.
I sent it over to you and Anne yesterday, I believe. It was in a folder. A zip folder.
Okay. All right. Okay. I will pull that up, and I will have that as an example. But if it's not 5.1C multilingual, I will just port over the numbers so that we're all working with the same version. Okay?
I think for the Nigerian, this is the 5.1C version.
The which C?
Nigerian.
Is 5.1C?
1C, yeah.
Thank you. Thank you very much. Okay, great.
And that's what we received, but do we have the same screen and treat version that you're working on as well? 1.0.1?
I'm going to go check that to make sure that you are working with the same one. Also, there's two versions. There's the developer version, and then there's the user version.
Mm-hmm.
The developer version allows you to make changes using Modano and Excel. The user version does not.
Mm-hmm.
So you will be using the user version unless you want to learn Modano, which I don't think you do. It took me about 1.5 years, 2 years to really get up to speed with it. But I will be using the developer version to demonstrate it. The only difference will be is that I will be able to add or subtract certain things as we go along that you wouldn't be able to do. Okay? And also.
Yeah. So Wim.
Mm-hmm.
So just to say that the difference is then also that not all worksheets, I think, in the developer version are visible in the user version.
Okay. That might be correct. I think I'm going to go check. Since that's more than a week away, I haven't checked so carefully. I was focusing on vaccine today, so let me check that and make sure that we're not causing any confusion with our folks here. Okay.
Yeah.
And
the other thing difference also with the screening version is that it only comes in English for now.
Yes.
To think about in the future.
Yes, only in English for now.
Even in Swahili, I think. So several languages.
I think we cut back to just English and French in version 5. Yeah, because not anybody. Yeah. Okay. All right. Well, then I'll say thank you to everyone. It's been great talking with you and getting an idea of what you need, what you don't need, so that we don't waste your time as we're moving forward. As ever, if you have questions that are burning or are frustrating you, we have our email addresses. If it has to do with the model, it's win, like you win a football game, at levinmorgan.com. And if it has to do with health economics or the big buck stuff, that would be Ann, A-N-N, at levinmorgan.com. And if you send the question to both of us, it's more likely to get answered than not, and sooner. Okay?
Great. Thank you very much.
Thank you all. And until next time.
Can I pose one question?
Oh, yeah, sure.
Because next week I'm on a flight when we have the call. So would it be possible to have the call 1 hour later so I can join?
1 hour later, did you say?
Yes.
Fine with me. It's up to the other participants. I'm not the.
Of course.
I'm not coordinating this. Thad, you're the overall coordinator, aren't you?
Yeah. Quick vote. Does anyone object 1 hour later on Wednesday?
Well, I'm going to be traveling as well, so I don't think I can make it in any case, Fayad. So you should go ahead and book whatever works for everyone else.
Yeah. Also, these sessions are being recorded, by the way, and I'm just emailing the recordings to everyone also.
Yes, that's wonderful.
Okay, so we're staying at the same place, same time, same channel, yes?
Sure.
Okay, great.
Is that okay with everyone?
Okay. Thank you, guys.
Sure.
Have a good
Thank
day.
you. I can chime if it, whatever works.
All right. And, and again, if you get frustrated, if you get stuck at any time, send us an email, please, okay? Because I've been frustrated with this, and hopefully I can help you get through things more quickly than if you try to do it yourself after being frustrated for a while. So until then, I'll say bye-bye.
Okay. Thank you.
Thank you.
Bye to
Bye,
everyone.
guys.
Bye.
Bye, everyone.